Hello, this is Brian Woods, and this is the video tutorial for the new OPIN forms that are being distributed to your facilities. The OPIN Reporting Initiatives is the Operational Performance Improvement Navigator system that we've been developing over the last year at North Star Anesthesia and Mira Healthcare. This system allows us to track data points from all of the anesthetic cases delivered in our system and then create metrics and reporting initiatives for the hospitals and ASC partners that we have in business. What we're going to do today is simply review the form that is being distributed to your facilities and make sure that every provider understands how to answer the questions and how to enter the data onto this actual form. Let me first say I completely understand it is no fun having more paperwork to do in the operating room, and we're certainly moving towards systems and investing a lot of energy and money to having systems that will allow us to be a paperless and a non-duplicate entry system in the future. In the interval, though, we do ask that each of you provide us one of these pieces of paper for each form, and after you're familiar with the form, it actually takes about 30 seconds or less to enter all of the data. So we'll begin at the top of the form, beginning with OR efficiencies. The first question that we need to answer for your case today is this case on time? Was this an on-time start? We define that in North Star as in room less than or equal to posted time on the board. Simple yes or no. We measure on-time starts for first cases of the day and for cases that are first case for a new surgeon. Example, a new surgeon posts a block after lunch at 1:30 to begin. That would set the new posted time, and we would measure that. If we have to say no to on-time starts, we need to know what the delay was due to. Either it was us, it was the patient not showing up on time, or a patient reason, a facility reason such as they didn't pull the instruments or have things ready to go, or every once in a while the surgeon doesn't show up on time. So we need to check that box there. Next is the incision time. We need all times on this form to be entered in military 24-hour time. If need be, you can enter the leading zero here for like 0732 for your incision time as needed here. The next three questions ask information in regards to anesthesia turnover time. Was this case a two-follow in the same room? If so, we check yes, and we're going to measure the end time from the first case and the start time of the second case, or the B case. The B case is the actual case you're in at this time. The end time for case A would have been your first case, and this would be your first two-follow case. And so from that you can see where we can deduct anesthesia turnover time in that scenario. But we only measure those on cases that are two-follow in the same room. The next thing we need to know is inpatient versus outpatient. Inpatient are those that have been had surgery and going to be admitted to the facility overnight for an inpatient stay, or perhaps they came to you from an inpatient location prior to surgery. The next question we'd like to know is, was the anesthesia screening accomplished prior to date of service? We need to know yes or no. We track for both outpatients and inpatients how often we accomplish that prior to the date of service. Final question in this metric is same-day add-on case. Obviously, if it's an ER add-on appendectomy at the end of the day, or a semi-emergent / elective hip that gets posted at 2300 at night, if it was added that day, we cannot accomplish the screening prior to date of service. So we need to know yes or no for same-day add-on so we can call that data out. From that series of questions, we can report multiple metrics on our OR efficiencies and how we're doing with throughput of the hospital. The next section is the antibiotic prophylaxis. This will be familiar to most of you who have been utilizing the quality sheets or the green sheets at some locations. First question is, surgical antibiotic prophylaxis was indicated by the skip or other protocols of your facility. If your facility has those, you'll know that, and you just need to answer yes or no. Even if it wasn't required by some protocol, did the surgeon order any additional prophylactic antibiotics, yes or no? If yes to either of these two questions, we need you to tell us what drug and dose and at what time you gave it. So most of the time it's ANSEF, greater than 80 kilograms, we give 2 grams versus 1, but maybe you gave some other antibiotic and we need to know the dose. And then again in 24-hour time we put the antibiotic start time right here. The final three boxes correlate to the bottom of our bill tickets, and these are the codes that generate to report this PQRI initiative to CMS. PQRI is the Provider Quality Reporting Initiative, in which our goal is to report greater than 80% of the time on CMS cases. So to simply check, I gave the antibiotic on time, 60 minutes prior to incision, or I have 120 minutes prior to Vanco Levaquin, or I need to check antibiotics were not given for a reason. For example, it's an IND of an abscess and they don't want to give antibiotics until after cultures are drawn, or any other medical reason, we would check here. Final box is antibiotics were not given, I don't have a reason, I just didn't do it. That would be the box to check right there. The next PQRI measure that's on our sheet is the normothermia measure. This is a new initiative that was put out January 1st of 2010 by CMS. First question is, case greater than 60 minutes, yes or no? If it's shorter than that, we don't even care. We don't measure this metric. If it is greater than 60 minutes, we want to know that the patient was warm on arrival to the PACU or the ICU greater than these two temperatures right here, yes or no. Even if we say no, though, we can check what warming measures we attempted. These are the three that are approved by CMS. So if we check any of these boxes or can say yes to that, it means compliance with this metric that we kept the patient warm. So even if the temperature is cold, but we check one of these three boxes, we get credit for the metric. There are two disqualifiers for this particular. Obviously, if we intentionally cooled off the patient, say in a cardiac bypass case, or active warming was not indicated, i.e. we just did a peripheral block or a beer block and the patient's central ability to regulate their own temperature was not knocked out, we can check this particular box. Or the final box here is active warming was not performed, we didn't achieve the temperature and we don't have a reason. Again, very similar to we didn't give it antibiotics and we don't have a reason, but that generates a code that we can report on that particular normothermia metric. The next metric is pretty straightforward. It's major cardiac cases only, so we completely understand that the ASCs in multiple facilities for their entire lives will check the NA box on this particular one, but for those that do major cardiac, we need to know the following two things. Glucose levels were monitored during the case, yes or no? And if we did monitor them, did we do well with it? Did we get management of glucose under 200 within 30 minutes of arrival to the PACU, the ICU, or at the end of the case? So yes or no on those two, for those of you that it applies to. Next section is the beta blockers. The beta blocker section is been debated back and forth for a couple of years now, especially since the POISE data came out. But general consensus is if the patient has been on a beta blocker prior to coming in for surgery, then we would like to give one within the 24 hours of the perioperative period. So, patient on beta blocker prior to admission, yes, no. If no, you're done. Don't have to do anything else. If yes, we need to know one of the following three things. Either A, the beta blocker was taken by the patient and their home dose was taken last night or this morning, date and time and drug. Option B is we're planning to give something beta blocker intraoperatively as needed. So maybe I'm going to give 1 milligram of metoprolol in the middle of the case. Or option C is, beta blocker was contraindicated. The patient's already bradycardic or has an issue, so we're going to check that. Or there's some other medical reason I'm choosing not to give a beta blocker in this particular case. So one of those three things must be checked if we have a yes box here. Final one is the central line placement. The central line for CVP or pulmonary artery catheter insertions needs to be documented, and they're wanting to make sure that we do that with sterile techniques. So again, most facilities are going to check NA if you don't do them often, but if you do put one in or both, we need to know that here. We need to know who put it in. The MD did it, the CRNA did it, maybe the surgeon got involved and placed it in this case. We need to know what site, either the right or left IJ, subclavian, or the femoral access point was used. 6 questions here to determine whether or not we did the sterile technique appropriately. So we performed the timeout, we washed our hands, we prepped with chlorhexidine, we used a large drape, everybody wore a glove, hat, mask, and gown, and we maintained a sterile field throughout. If you say yes to all 6 of those, congratulations, you get to check sterile technique was followed. Or there's 2 other boxes again here for the reporting process that allow us to say we did not follow the technique for either a reason, patient needed a line and had to have blood immediately, so it was an emergent situation, we didn't follow it, or again, we just didn't do it, we don't have a reason, and that's all that we can say there. Let me scroll down a little bit further here to capture the bottom of this form. Here we go. So at the bottom of the form, you'll see there's just some signature blocks. There's some blocks here for the bottom of the form that indicate a provider ID number. It's not yet been distributed, but will be coming to you very soon. As you can imagine, it's hard for us to detect signature recognition sometimes. And then finally, date and time has to be noted on any signature on any medical record of any time. This is a new JCO hot topic, so please be aware that that has to be done, and date and time all of your signatures for every medical record injury. At the end, these are going to be collected just like your bill tickets. You're going to drop them in the bins that are appropriate at your facility. And there's 2 ways to get these to our corporate office. One, you can put them in the bill pack with the information that goes to ABIO every week. Or if you're in the Dallas-Fort Worth area, you can go ahead and put those in inter-office mail and get those to our corporate office. So that completes the review of this form. If there's any other questions, please don't hesitate to talk to your medical director or your chief CRNA, or don't hesitate to call myself or Andy Dameron, Executive Director of CRNA Services. Appreciate your time and appreciate all you do every day to make sure that this metric system gets put into place, and we'll talk to you very soon.